Good day, everyone. Thank God that today we are all healthy and safe to join this workshop. My name is Angelina. I'm from Telkom University, Indonesia, and I want to present to you today our paper entitled Process Mining on the Extended Event Log to Analyze the System Usage During Healthcare Processes, with a study of the GP tab usage during chemotherapy treatments. I wrote this paper along with Owen Johnson, David Hawke, and Jeff Hall from the University of Leeds in the UK. As an introduction, we all know that patient treatment is very complex. It is affected by many things, including patient condition, and then procedure of the treatment, and also how the hospital set the system to support the treatment. We can use process mining to visualize and analyze the treatment pathways based on the clinical records of the patients in the EHR system. But we also know that the EHR system is very complex. That's why in this study, we want to try to see how the EHR system affecting the patient treatments. We have a real case study from the real data set in the patient pathway manager in PPM in the LTHT. And this is one of the largest hospital system in the UK. It was developed in 2001 to support cancer data collection. So the system was built to support cancer treatment, but it was underpinned in 2013 for trustworthy hospital information system at LTHT. Last year, it had 2.4 million patients, including more than 350,000 cancer patients. In this study, we followed the process mining project methodology that was originally have 6 stages, but we excluded the last one because we cannot apply our finding to the real settings in the hospital. So we have 5 stages instead. The first one is planning, second one is extraction, and then we have several iterations of data processing, mining and analysis, and evaluation. For the planning, we discussed with the clinicians and we set our scope on breast cancer patients received EC90 adjuvant chemotherapy with the main research question on how GP-TAP access was done during chemotherapy. And then we have combination teams of technical and clinical, where we have direct access to the hospital, so we can access the developer team and also the clinical experts in oncology. Then we extracted our data set from 2 different sources. The first one is clinical records of patients from the PPM database, and the second one is user access records from PPM Splunk. Then we processed our data by creating views of the patient, and then we didn't do aggregating our events because we use the fine-grained events instead. And then we also enrich and filter logs through several stages. On the next one, we did mining and analysis using PROM, DISCO, and BUPAR with a focus on analyzing GP-TAP usage during chemotherapy. We also did evaluation on the statistical and clinical aspects. On the planning, we set our research questions. We had 2 research questions. The first one was, what are the most followed paths and the exceptional ones? And then the second one, how did clinicians use GP-TAP during the course of chemotherapy? As I mentioned before, our data set is clinical records of breast cancer patients receiving EC90 who was first diagnosed between 2014 and 2018 and who had the GP-TAP accessed by clinicians. For the illustration on the right side, we can see how clinicians have the view of patient during the treatment. And then every time the clinicians need to see patient records in different providers, such as GP, and then social care, community care, they can go to different tabs to see patient details. And then in the data extraction, we combine two sources, clinical records in DHR and also user access log in Splunk. This is actually the main challenge of our study, where we have two data sets with two different structure. The first one, for the clinical records, we have a relational database. And for the second one, we have web log of user access log. And then we combine those two data sets into one event log. Then we analyze the event log using PROM, DISCO, and BUPAR. As the result, based on the selection criteria of lead patient diagnosed with breast cancer receiving EC90, whose GBTAP was assessed by clinicians, we selected 738 patients. If we see the numbers here in the table, we see that in the cycle 1, we have 738 patients. But along the way, during the cycles of chemotherapy, we see that the number of patients are decreasing until in cycle 6, we have 380 patients completing cycle 1 to cycle 6. Then we also have additional events, emergency and neutropenia, which was suggested by the clinicians that those are two adverse events that usually affected patient on whether or not they will continue the cycles of chemotherapy. Then we did some data processing. We created views based on the chemotherapy cycles of breast cancer patients. And then we enrich log by adding process durations and include two adverse events, which are emergency and neutropenia. For the emergency, we add these events based on the admission type in the admission table. But for the neutropenia, our clinical experts check the neutrophil count and decides which ones are the neutropenia events. And then we did the filtering based on the attribute, and we create event logs to select case ID, activity, resources, and timestamp. For the mining and analysis, we got some results. The first one on the left side is the dotted chart, which can show which patients have completed cycle 1 to cycle 6, which is the middle part. And then we can also see on the top part that some patients cannot continue the cycles until cycle 6. Some of them have to stop in the middle of the chemotherapy. And then for the last part, the bottom part, we have some patients who have more complex cases with a lot of more events happening until 7 years. For the second analysis, we check on the trace variants, and we found that the most followed variants is cycle 1, 2, 3, 4, 5, 6 in sequence. And then the second one is cycle 1, 2, 3, then stop, meaning that the patients didn't complete the cycle of chemotherapy. They stopped at the cycle 3. We discussed with the clinician why did this happen. They said that maybe because this patient might have changed the regimen of the chemotherapy, which is outside the scope of this study. And then the third one, we have cycle 1, cycle 2, cycle 3, and then emergency, and stopped. They didn't continue to cycle 4, 5, 6, meaning that these patients had emergency admission that stopped them from continuing the cycle of chemotherapy, and so on. And then we have the third analysis on chemotherapy cycles leading to an acute event. We find that for both emergency and neutropenia, most of the patients got this acute event after cycle 3. And then we also analyze how GBTAP access during chemotherapy cycles. We add one event on the event log of cycle 1 to cycle 6. we add one GP tab event, and we can see how GP tab was accessed during chemotherapy. Most of them was accessed after cycle 6, but also after cycle 3, cycle 4, and cycle 5. And then we also add some analysis on GP tab usage, where we can see on the right side, on the top one, we see that the usage of GP tab was increasing along the way from 2014 until 2018. And then we also found from the data that we can see system updates at around 2018 on January, where they changed GP tab from the first version to the second one. And then in the evaluation stage, we have technical and clinical evaluation joined by developer team of the PPM EHR system with the clinical experts of the LTHT. We got some findings from the evaluation. The first one was that process mining can be used to model and analyze patient treatment. And then we can see GP tab usage increased over time. And the last one, we can see how clinicians use GP tab during cancer treatments to access patient records in the GP system and support their decision on patient treatment. As the conclusion, we proposed an approach, process analytic approach, which combine patient clinical records with user access log to analyze system usage during patient treatment. We show the applicability of this approach through a case study of GP tab usage during chemotherapy treatment, where we found that the most followed paths can be analyzed through the process model, trace variant list, and dotted chart. And then the GP tab usage during chemotherapy can be modeled to enrich the process model. As the future work, we have 3 points here. The first one is to explore the aggregated events on a higher level of pathways, meaning that we can explore how patient has the pathways from referral and then diagnosis and then several treatments until they are discharged. And then the second one, we want to use user access log to find missing events in the EHR system. I think this is potentially useful in most cases because we know that the EHR system recording clinical events of the patients are mostly incomplete. So if we can add user access log, we might find several events related to the patient treatment. And then the third one, we can explore possible ways to select the best set of events independent of clinical inputs, meaning that in this case study, we use clinical inputs from the clinical expert to set the events that we will use in this study, but we want to explore a more automatical way to find the best set of events without input from the clinical experts. Okay, that's all for my presentation. Thank you for your attention. And I'm looking forward to your comments and your inputs to improve our study. Good day.